Hello, my name is Oskar Voll. I'm from the University of Medicine, Pharmacy, Science and Technology, George Emil Palade of Targu, Romania, and I want to present you my case report, Antral Gastric Cancer with Gastric Outlet Obstruction, Preventable by Screening. So first of all, to the background, gastric adenocarcinoma is the most common type of gastric cancer with the most common location, the lesser curvature. Early stages are usually asymptomatic, whereas later stages have unspecific symptoms such as weight loss, loss of appetite, nausea, and thus leading to a late diagnosis in most cases. This raises the question of screening methods and early detection of the cancer. And there is actually a screening program in Japan recommended by Japanese researchers. That is why I want to present you a case of gastric adenocarcinoma with the complication of gastric outlet obstruction to set more focus on screening methods established by the Japanese researchers. So in the following, I will shortly present you the case. We have an 82-year-old patient presented at the hospital with regurgitation, vomiting, and weight loss with a history of subtotal colectomy for colon cancer 5 years ago. General examination revealed a tumoral mass palpable in the hypogastric region, and CT showed evidence of a tight tumor stenosis in the duodenal bulb and T1 with aging tumor adenopathy, multiple hepatic metastasis, and right and left portal branch thrombosis. Also, biopsy through esophagoduodenoscopy was performed, confirming the diagnosis of low-grade gastric tubular adenocarcinoma, which is moderately differentiated. Due to the outlet obstruction, palliative intervention through laparotomy approach was performed, and additionally, liver biopsy confirmed the presence of liver metastasis seen on the CT. Also, adhesiolysis of the proximal part of jejunum with gastroenteral anastomosis was performed. Now, in the following, I want to quickly show the difference of the extent of the resection in a late and early gastric cancer stage. Here in the first picture, you can see an extended resection of locally advanced gastric cancer with removal of 4/5 of the stomach, head of the pancreas, omentum, and transverse colon, plus D2 lymphadenectomy. The next picture shows an antral gastric cancer in early phase. So the specimen is after subtotal gastrectomy, omentectomy, and lymphadenectomy. So in these two pictures, you can clearly see a huge difference of the extent of resection and thus the impact for the patient. This raises the question of early detection of gastric cancer. And as mentioned before, there is actually a national screening program for gastric cancer in Japan. And these guidelines of the Japanese national screening program recommend every 2 to 3 years endoscopic screening for adults older than 50 years. And there are actually studies supporting the screening program, which suggest that the screening program is cost-effective and prevents approximately 63% of gastric cancer mortality compared with no endoscopic screening. Thus, endoscopic screening might be beneficial in other countries as well, since gastric cancer is detected at earlier stages compared to Western countries, and the overall survival rate of gastric cancer is higher in Japan. Lastly, I want to add this microsimulation where modeling a dynamic individual risk profile led to a natural history of gastric cancer. And this microsimulation did estimate that the current screening program is less cost efficient than this model recommended strategy. Thus, the screening program in Japan might have to be reconsidered and more studies have to be conducted to develop a sufficient screening program for gastric cancer. Thank you for your attention.